Um, Good morning, everyone. Today I'm talking about our audit project on permanent pacemaker insertion after heart surgery in Leicester. So why do we do this? A transient conduction problem are common after cardiac surgery, and pacemaker insertion, permanent pacemaker insertion is not as common, but it increases the length of stay and cost of care. And it's not benign either. There's always a risk of complications like hematoma, hemothorax, and tamponade. But perhaps what's most feared among the surgeons is risk of infection long-term, which is about 5%. So we look at all patients that underwent heart surgery from 1st of January 2007 to 30th of April in 2012, and that gave us quite a large number of 5,760 patients. We excluded patient who's already got a pacemaker preoperatively and patient who's already in a complete heart block before the operation. So that gave us about 5,684 patients. And out of these 5,684 patients, only 174 patients ended up with a permanent pacemaker, which gives us about a rate of 3%. So this just illustrates the pacemaker insertion according to different types of surgery. So valve combination is actually a multiple valve surgery, a double or a triple valve surgery, so AVR, MVR, and TVR, or just MVR or TVR or AVR and MVR. So we can see that out of 235 patients, 33 patients actually needed a permanent pacemaker in the end. With AVR and CABG, there's not actually much difference in terms of number. So in MVR, we include both mitral repairs and mitral valve replacement. And if we look in the CABG groups, only 10 patients out of 2,594 needed permanent pacemaker in the end, which is negligible. In the other groups, we include patients who's had operations on the left ventricle, so aneurysmectomies and operation for dissections. So this basically sums up our finding, and you can see that CABG has the lowest risk, which is about 0.4%, and the highest risk is in multiple valve surgery, which is at 12.3% risk of permanent pacemaker insertion. And valves in general, aortic and mitral, gives about 4 to 5% with or without CABG. So multiple valve surgery has at least twice the rate of pacemaker insertion compared to AVR, and it's 3 times compared to MVR, mitral valve surgery alone. And CABG doesn't really make any difference to valve surgery when it comes to pacemaker. So our findings are consistent with what's been published in previous literatures. Requirement for pacemaker implantation after surgery in general is about 3%, and following AVR is about 5%, and after CABG, ours was 0.4%, but what's stated in the literature is about 0.4 to 2%. and highest after multiple valve surgery, which is 12%. In our center, permanent pacemaker is generally required for complete heart block and slow AF post-op. So interestingly, as early as 1993, there has been attempts at predicting which patients will go into, will need a permanent pacemaker post-op. And if we look, right bundle branch block actually gives us 2 points, and left bundle branch block only 1 point. That's probably because post-op patients, most patients will develop a sort of a left bundle branch block. So having a pre-op left bundle branch block gives you a higher point because then you'll end up with a complete heart block. And multiple valve surgery is already on there, especially when a tricuspid valve is involved. And what we've observed, chronic or persistent asymptomatic AF also has a high rate of pacemaker insertion post-op, and especially patients who are heavily beta blocked or on antiarrhythmics with poor LV. So there are other risk factors intraoperatively, like redo surgery, a prolonged cross-clamp time, calcification in the annuli, and mitral valve replacement as opposed to repair. And minimally invasive mitral surgery gives a lower rate of permanent pacemaker, and continuous suture for aortic valve surgery gives a higher rate of permanent pacemaker insertion. So in our center, patient who has a multiple valve surgery tends to they tend to be mitral valve and tricuspid valve surgery, and these patients tend to be patients with asymptomatic chronic persistent AF, and for these patients they will have RFA during the operation. I mean, we observe that post-op they sort of go into a slow nodal rhythm, which requires a pacemaker. But these patients are recruited in a maze trial, so the data is not available for us to look at yet. Interestingly, surgical AVR has significantly lower risk of permanent pacemaker rate compared to TAVI, which can be up to 30% in core valve. So what's the implication of all of this? So consent process for patients, so we can tell them what's the rate of, what's the chance of them getting a permanent pacemaker after the operation. And early referral for pacemaker insertion so that they could mobilize early and hopefully go home earlier. However, that's debatable because in about 60%, only 60% of the patient actually becomes pacemaker dependent in the long term. So 30% of them actually recovers, but that's taking up from 6 weeks to a year, really.